So John's going to come up and talk to us about TAVI. I think our first talk about TAVI, right? So that's great.
Yep.
Who doesn't benefit, even if they're a nice lady?
Nice title. And seeing people at their one-year follow-up, those who don't come, it makes you wonder. But also those who come and you ask them, well, how does it feel to have a new valve? Well, I don't feel any better. So
Yeah.
need to think about these things. So questions, I think I submitted a few. Using the KCC score as a metric of patient-reported health status, a score of 15 suggests that the patient is dead, feels great, is quite miserable, does not need treatment.
Kansas City questionnaire.
We're not from Texas.
So either feels great or is quite miserable.
All right, next. The AUC criteria for TAVI are created to provide clinicians with guidance, be used by Medicare for reimbursement, our patient-reported assessment of benefit from TAVI, identify centers that do not know what they are doing.
It's not coming. The question is not coming.
Yeah, it's not coming from
Open the
service.
poll, please.
It just opened.
No, wait. They have to open it.
Now it is.
Yeah.
What does AUC stand
Criteria for TAVI.
Ah, that's good.
He's not from North America.
He has a PhD.
Use of non-Senate acronyms is from.
All right, and I think there's one more. University of Colorado Hospital has better than average results on the Alive and Better metric to assess benefit from TAVI due to hypoxemia. There are more marijuana dispensaries in Starbucks.
I'm going with
Great interventionists. No one's answering that. They only treat people who are demented.
John!
All right, let's begin the talk. Okay, so disclosures. Appropriate use criteria is what AUC stands for, and this was a multi-society committee that published last year the appropriate use criteria for the treatment of patients with severe AS. What is it? An appropriate treatment is one in which the potential benefits in terms of survival or health outcomes exceed the potential negative consequence of the treatment strategy. You know, I think with the pulmonic valve stenting, the discussion this morning is, you think about that a lot. So how does it work? Well, there's a writing committee that comes up with different scenarios, clinical scenarios seen in practice, and then there's separate panelists who then rate each of those patient scenarios in terms of whether they think they're rarely appropriate, maybe appropriate, or are appropriate. And that's done with a group, and then a mean comes out of that. So the rating scale, the panel has a score of 7 to 9, suggests that it's consensus that there's appropriate for a specific indication. Yellow is maybe appropriate, and red is rarely appropriate. Doesn't mean it's contraindicated. It's just different levels of certainty as to whether a treatment option is appropriate. So let's take some examples with TAVR. And so there are actually 4 different interventions that were assessed in these 2 specific scenarios. The first one, 46, severe AS, a moderate risk to high risk for surgery, oxygen-dependent lung disease, shortness of breath, BNP normal. And you can see that no intervention was maybe appropriate, but the TAVR was considered to be the most appropriate, SAVR less so because of the surgical risk, that it was rarely appropriate. And the second scenario, severe AS, moderate to high risk, oxygen-dependent lung disease, shortness of breath, BNP elevated, and that kind of excluded that doing nothing would be a reasonable middle appropriateness and increase the likelihood of the appropriateness. So do you get a feel for what this is all about? Renal failure, this is a common scenario where you're seeing someone with dialysis, and these two scenarios are 48 and 49 differ in that the first is someone on dialysis who's not a transplant candidate. And now we know that at 1 year, 50% of these patients are dead after TAVR. And the other 50%, we really don't have quality of life data, but it's still not looking very good anecdotally. While down below are those people in whom doing valve replacement, either with transcatheter or surgery, enables them to go on and have a renal transplant. So, liver disease. Again, here you see the different MELD scores, and very high or not so high, but talking about TAVR being appropriate in that subgroup. But malignancy, 53 and 54 are contrasted in terms of what is the expected life expectancy, where those who have a malignancy but have a good chance of being alive over a year, then there's a higher appropriateness rating for TAVR, but if their life expectancy is less. So this is the way the AUC criteria. And then they did something interesting. They started expanding it to more than AS. What if they also had severe aortic stenosis? And you see three different categories of severe AS and severe MR: high surgical risk, intermediate surgical risk, and low surgical risk. And you can see that SAVR plus other surgeries, there are additional case scenarios where they were bicuspids with aortopathy or subaortic gradients. So this is a way, yeah, go ahead.
Sorry, just a question. So high surgical risk is like what?
STS
Above 8.
Yeah, above 8. 3 to 8 is intermediate, above 8 is high, and above some higher number is prohibitive. Okay, so now, going back to Our Lady, what do you want to be talking to your patients about? The potential benefits, the reduction of symptoms, reduced risk of AS are the two main things, but increasingly in an elderly population, you want to broaden those considerations to functional state, quality of life, reducing hospitalizations, the need for other treatments. And not infrequently, we see people who, the worst thing about their quality of life is that they have severe hip pain, but no one's going to do a hip replacement until their AS is treated. So that's there. So, but the caveats are symptoms, limitations, and reduced quality of life may be related to comorbid conditions that may not be impacted by transcatheter valve replacement. And what about the life expectancy limited in the 80-year-olds? So if you look at U.S. Census and Medicare data, if you're 80-year-old, the average life expectancy is 8.7 years. If you're 90, 4.6. So you have to put that in the context of talking to that woman about TAVR. So new metrics of success, living longer and better, is kind of the buzz slang coming from our Medicare organization as well, and how to quantify it better. Actually, the KCC questionnaire results are now being accepted by the FDA as part of the approval process. It's been validated enough, used broadly enough, and has enough importance in terms of patients' satisfaction that it's used. What is it? Well, it's not just quality of life. And if you read it, and if you've never read it, you should, because it helps you basically do a history, a structured history that helps determine, in the patient's own assessment of their symptom burden, how independent they are, what sort of limitations they have. And so very poor is less than 25. These people are really bad off. And those who are up to over 75 are not so. And you can the Kansas City group actually made some correlations in New York Heart classification. A change of greater than 10 is significant. That's been shown, and it's been shown to be useful in terms of prognosis in TAVR, and it's useful in identifying good and poor outcomes, and it's available in many languages. So this is a very interesting graph where on the vertical axis you've got the post TAVR KCC score, and on the horizontal is the baseline. So if you're 50 at baseline and you become 90 post, that's up in the white area of acceptable. But if you're 50 at baseline and you are 30 following, say someone had a major disabling stroke, that would be a common cause for someone to have a decreased quality of life. So this is an interesting conceptual framework. One of the questions that's facing us is whether it should be a site performance metric. That is, if you look at your patients you've treated, say 30 days or 1 year after, how would you rate? How often do you think your patients really are having this definition of an acceptable outcome? And Suzanne Arnold and the group also applied this recently to the TVT registry data, showing in the graph of the general significant increase, average pre-TAVR KCC score of low 40s, rising to the mid 60s. But according to their way of stratifying favorable outcome, only 62% of patients met that. So is that meaningful or not? Does that mean those patients shouldn't have had the procedure because they didn't meet these benefit criteria? That's the type of issue that I think is front and center, and especially for payers. They want to know, given the expense of TAVR, and at least in the US, our average cost is around $32K. It's about half of that in Europe for the same device. So it's very expensive. This is a metric we now report to sites quarterly, there are 579 US sites doing TAVR, and every quarter they get their results. And so this is the patients with improved acceptable quality of life outcome at 30 days based on the KCC score. And it means they're alive, have a 30-day KCC score over 45, and a 30-day KCC score that's 10 points higher. And so the 50th percentile U.S. hospitals is 55. That's why I say we did well, because we pre-treat everyone by the stop in the dispensary before they come back and fill out their KCC score to feel better. Just kidding, of course. But you can see how this is an important thing to consider in these treatments of patients who are elderly, who have comorbid conditions, and it's quite a high bar. And again, while they say this score is disease specific, it obviously is not. People have disabilities and quality of life less. So is there any way we can do a better job of patient selection? Can you predict the likelihood of being alive and better at 1 year following TAVI or TAVR based on pre-procedure characteristics? And that's what the algorithm development group in the TVT registry is now working on. And you can see how, from your clinical experience, some of the tip-offs for people who are likely to feel much better if their main symptom burden is related to AS versus those unlikely to, like those patients with dialysis. And this goes back to, we're terrible at denying treatments to patients because it goes against the grain of our ethos, unless we feel there's a great potential we could harm the patient. And given the dramatic reduction of the risks of TAVI in the last couple years, some of it is lower risk patients entering it, you still would like to have the decision going forward or not in these borderline cases of benefit clearly outlined. And rather than you playing the yes or no, often these people from the greatest generation are very capable of making decisions about what they want. And if you tell them at 1 year your chance of being alive and feeling better is 90% versus your chance of being alive is 50% and feeling better 20%, a lot of people take that seriously and make decisions. How accurate are these algorithms, predictions, is obviously important. So it is a given that some people do not benefit. Tools to predict will be helpful, but never be perfect, and the thresholds will be arbitrary. AUC helps define the case scenarios and need to be updated because they're clearly dependent on current available data and treatments. And should we look at sites in terms of how well they perform at this metric? It gets more into the heart of patient selection rather than procedure performance, but boy, that's important too. Thank you. So, want to do a few questions?
Questions? Eric?
So I guess it's very interesting when you start talking to patients about how they want to be alive. And there's a huge, it's not really for Medicare or CMS or whatever to decide what's right for an individual patient. Because some patients want to be alive at any cost, while others are, they're very proud to say, look, if I'm not going to be good, I just don't want to be alive, that's fine, I don't care, I've lived a long time. It's very interesting to have the perspective that you would take the autonomy away from the patient to make the decision with the proviso that they're an appropriately informed patient and have kind of a central, that's not very American, if you'll pardon my expression. It's kind of more of a Canadian thing to do. Right? America is like, you're in charge of your own destiny, you choose what you want, and you know what I mean? I'm just interested in that whole perspective on it. You know what I mean? Like having the decision of how to proceed based on a number of how well you're going to be, and not leaving it up to the patient themselves to decide.
Yeah. Well,
I mean,
go ahead. You want?
No, I think it's a great point. Another population that is a challenging population, irrespective of their frailty scores and other comorbidities, is the population who has paradoxical low flow, low gradient with a normal EF, and they feel short of breath, and they have a mean gradient of 18, and their valve area is 0.9 because their stroke volume's low. And their calculations on echo derive show you that the valve, but when you look at the valve, it doesn't look critical, but they're short of breath, and they feel like something needs to be done. And if you don't do it now, why are you going to wait? Because in 3 years, I'm not going to be 85 anymore, I'm going to be 88, or I'm 80, I'm going to be 86. So why are you waiting? Just do it now. And that's I find a very difficult population to deal with, and I see actually a lot of these patients, and I struggle talking to them. I don't know if I think that's a separate pocket that I don't know how you address that. It's not being addressed, in terms of what you're describing today. But
well, it actually, that was one of the scenarios in the AUC, is people who have low flow, low gradient. But you bring out a great point. Randomized clinical trials don't give us the answers or any data to help advise patients on making informed decisions in a variety of different scenarios. And that's one way where we think registry-based data can be very powerful in at least giving some data. Again, predictive models will never be perfect, but some insights into how well these people do is important. If it was my own parents making a decision, I would want to have some data to inform them. And it's very useful in raising expectations. One of the things at least I've started doing, is being very straight with what a person can expect. It's not the fountain of youth. You're not going to go from 85 to 65. You're going to be back to where you were a year or two ago. And if you were miserable and you couldn't walk and you're on oxygen for your COPD, those things don't go away. Just because the straight facts have to be delivered in some sort of way to enable people to make decisions.
But the issue is because patients see it as a lower risk procedure. It's not open heart surgery. So it's one thing if they're coming in and they're saying, well, you're going to get cut open, you're going to be in hospital, you're going to be on a ventilator, you're going on a bypass machine. But we're selling it in the community, maybe not me personally or the people involved in doing it, but it's being sold as a low risk, minimally invasive procedure, in and out, X amount of minutes, less than an hour, blah, blah, blah. So they're like, well, if there's a chance I'm going to feel better, then let's do it. Right? And so you tell them the expectations, and they still want it.
But you know what, if the procedure cost $50, we wouldn't be having this discussion, right? We would just do it. It's all artificial. It's a totally artificial scenario. The companies are, at some point, someone is going to muscle them, and the price is going to come down. It comes down for everything, and it's going to come down for valves. They've been extraordinarily sensitive to what happened with drug-eluting stents and about how that whole market and that whole area disappeared. And they're just on price protection like 100%. And, just going to say, like, Canada is going to make a decision that, well, we're going to buy valves from one person, and it's going to be at this price point, so either you're in or you're out.
Yeah, Eric,
The U.S. government's going to buy valves from one person, and, bid for it, RFP. Go for it.
Not one person, but
I think I think the way you said it, John, where you said you're giving a patient an informed choice is the key, because you're right, Eric. There is no stomach in the public sector in the U.S. to take away the patient autonomy, whether they're 99 years old or 1 year old. I cannot see that happening. They're going to do it indirectly. And how they'll do it indirectly is they'll say, well, Denver has great quality metrics based on quality of life in their TAVI patients. You'll get paid more. You're going to get slightly a stipend or a bonus. But then what that does create the problem of is patient selection and like case mix and all that. If you can just take the easiest patients with the highest quality of life and get the best reimbursement. This is happening, and it's happening in places where there's a lot of competition in the U.S. We see it all the time.
I'm just saying Mark's question about low S. I really have a problem treating them too, especially since after you do the procedure, they're still left with a gradient.
That's
and when
right.
when they come back and their gradients are 20, and you bring it down to 15,
Mm-hmm.
and what
That's
if you
right.
done for 5 millimeters of mercury?
Yeah,
So for me, I'm very concerned when I treat these patients.
yeah, I agree.
Where does the marijuana stand to you?
Pardon?
Where does the marijuana stand to you? Tell us.
Marijuana. Where does marijuana stand?
Where do you stand?
The question is that.
With the marijuana.
Marijuana. No,
Everyone, okay, let's keep going.
it's a joke.
Okay, Saibo. What's that?
I just want a tiny fountain.
Yeah, okay.
Sorry?
Our next speaker needs no introduction. He's been doing mitral clips since he was a baby. He's going to teach us about the 10 most important keys to success in the mitral clip procedure.
No, there are no Canadians.
There's no Canadians.
I don't think there's Canadians on that.
No.
Are there?
No. It's the AUC.
Jonathan Leipzig was actually on it, yeah.
I think Wayne Gretzky's on it, maybe. But
Somebody wore a t-shirt.
Jonathan Leipzig.
Radiologist, isn't he?
Yeah, he's a radiologist.
What did I say? I just didn't say cardiologist. What?
What did he?
Oh, it was a CT. There was some
does he see
CT.
patients clinically and stuff like
I-
that? Okay.
All right. Yep. So it was a separate group that wrote the questions, then which is very important. And one more. Was there another one?
is there another question?
What percentage of patients that are going in the Arnold
Arnold.
report from the TVT registry did not have a favorable outcome?
15%.
Yeah, 33%.
Wow.
That's very high.